So thanks, good morning. Thank Yoda and Rafael for inviting me. It's really a pleasure. Been following this symposium since the very start. So I've been asked to talk about, to give an overview of the Sellar pathologies in childhood, which it's quite broad. As you can see from these confusing images, there you can have a variety of lesions which correspond to different pathologies with different behavior and of course management. So I would say to give order and structure to all these pathologies, which are not only craniopharyngiomas and not only surgical, I would just first of all give three key concepts about the epidemiology of all the Sellar region pathologies. They account around 10% of all primary brain tumors in children. And the clinical manifestation is fairly usual because, of course, it's related more to the location of the topography of the lesions. But they usually will involve either endocrine dysfunction, visual dysfunction, raised intracranial pressure from hydrocephalus, or neurobehavioral problems. And not least, asymptomatic lesions are increasingly common. One of the nicest, I would say, recent review on a cohort of nearly 4,000 MRI scans found at least 25% of incidentalomas in brain, generally speaking. Now, to give structure or to have an idea of how to sort of classify these Sellar pathologies, I would start from anatomy, which I would say always help, as in the anatomy of the site of origin of these lesions. Means that lesions then can arise from a specific compartment and they can extend to other compartments. So we would classify them in intrasellar, in infundibular, suprasellar, and third ventricular. So that doesn't mean that a lesion cannot go elsewhere, but at least one way of giving order to these lesions is to think about where they can come from. And so from there, you can go on about the differential diagnosis. So, I mean, this is an overview. So inevitably, I have to give you lists. We won't go through each one of them because there's too much to talk about. We won't talk about craniopharyngiomas because we will spend the whole day. But I would like to give you a few facts about other lesions that you might find in kids in the Sellar and suprasellar region. Going through this order about intrasellar, infundibular, suprasellar, and third ventricular. Then there is a bunch of other rare pathologies which won't talk about, but we just need to know that they exist. So, and I try to give like a differential diagnosis that goes together with the other lesions. So about the intrasellar, one pathology that I think as a pediatric neurosurgeon we should also keep in mind is the Radke-Klett cyst, which is it's a clinically benign lesion. Basically, it's not really a tumor as such. It arises from as you know, the pars intermedia of the pituitary gland. And it's fairly common in the end. It's been found at least on 11% of routine autopsies. And it does not enhance, and the signal varies on the MRI scan on T2 and T1, depends on the content of the cyst. The main differential diagnosis will be a craniopharyngiomas, which we'll have a nice lecture later on about the radiology of craniopharyngiomas, and can have absolutely asymptomatic and absolutely benign course, so they not always need treatment, actually rarely need treatment. I will skip the craniopharyngiomas. And other pathologies that actually arise from the Sellar region, so intrasellar, as you know, are adenomas, which are a bit rarer in pediatric population than in adults. They share the same radiological aspect, but the clinical course may be different. Most of the time in kids touches more girls than males. And macro, which is more than 10 millimeters, are slightly more common than micro. Functioning adenomas are also a bit more common. And they can also have cystic component from hemorrhage, which also comes into differential diagnosis with craniopharyngiomas. Either like pituitary hyperplasia, can mimic a pituitary adenomas, but they're not neoplasms, are just changes of the pituitary gland due to hormonal influences that depends on different conditions. So that one should keep in mind. Empty sella it's not really a lesion, it's like more a finding, and it's defined as a pituitary gland less than 2 millimeters and CSF occupying more than half of the sella. It does not always correlate with intracranial hypertension. Now, infundibular lesions, they usually present with diabetes insipidus, and I would say for the pediatric population, we should keep in mind the Langerhans cell histiocytosis, which is not really a tumor. It's fairly common pathology in childhood and not that much in adults. So it's the typical pediatric differential diagnosis, and involves typically not just the infundibulum, but also the white matter, gray matter, namely the brainstem or cerebellum, and also the calvarial bone, which is a very frequent lesion, and it's not clearly surgical pathology. Whereas germ cell tumors, they, as you see from this picture, they can arise typically from the infundibulum. Of course, they can have a suprasellar extension, and namely they can also locate, as you know, in the pineal region or even the posterior fossa, to have multifocal localization. Again, not purely surgical. I mean, usually it's biopsied and then treated with radio and chemo. So, and then can extend also to basal ganglia and other location, as I said. Lymphocytic hypophysitis, it's not a tumor either, but it can appear as one, as you see. Extends from the infundibulum again, and can extend in the sellar and suprasellar lesion. So, and then the clinical course varies depending on which part of the gland is involved, whether it's anterior, posterior, or both. Ectopic neurohypophysis, I've never seen one. It's been described, and it appears as a hyperintensity in the infundibular region, can be actually even post-traumatic from transaction of the stalk and migration of neurons in the infundibulum. About the suprasellar lesions, I would say the most important entity to remember is probably OPGs, which are fairly common in kids. I would say classify them whether they are related or not to neurofibromatosis type 1. They're actually chiasm and hypothalamic gliomas. Most of them are actually low-grade gliomas, very rarely high-grade or gangliogliomas, pinette. They can very rarely bleed, and roughly they account for 5% of all brain tumors. Again, they arise from the suprasellar compartment, so usually it's either chiasm or optic nerve, but they can extend in all directions, basically. And their clinical course will be, of course, different, but it's always not always as bad as they can look on the scan. Whereas in neurofibromatosis, usually you'll have more optic nerve involvement rather than the chiasm, and cystic component are and large extension are a bit more common in non-neurofibromatosis patients. They usually present with hydrocephalus, which is quite uncommon in NF1. Amartomas, other pathologies that can actually extend in the suprasellar compartment. They are heterotopic foci of gray matter. They, as you know, typically present with gelastic seizures. They've been morphologically classified in pedunculated and sessile, and fairly rare to be fair, but they can be also syndromic. The other lesion that I think needs to be mentioned, and it's fairly common, it's the arachnoid cyst, which is not neoplasm. It's again a benign, clinically benign lesion. Very rarely requires treatment, and the symptoms usually comes from mass effect. So mostly on endocrine function and visual function, very rarely can have actually hydrocephalus from obstruction. Can actually mimic aqueductal stenosis when very large and enlarging the third ventricle. And then very rarely lipomas, dermoid cyst, which of course will have and will follow the radiology signals that for lipomas for fat and dermoid cysts for the epidermic content. Third ventricular lesions, so they're not really Sellar pathologies, but they come from the third ventricle, from the anterior third ventricle, and they can extend in the Sellar and suprasellar compartment. The extremely rare choroid plexus papillomas that they usually locate actually the atrium or the lateral ventricles, but they occasionally can involve actually the anterior third ventricle. And again, ependymomas or metastasis. So key takeaways, not only craniopharyngiomas, so actually most of the pathologies involving the Sellar and suprasellar region are not surgical. But when you see a scan with an abnormality, then you should bear in mind that there are many other non-surgical pathologies. The clinical spectrum actually is fairly usual and regular, and usually involves either raised intracranial pressure from obstruction and obstructive hydrocephalus, endocrine visual dysfunction, and neurobehavioral changes. The differential diagnosis will be based on the age, symptoms, specific radiological patterns, and that will also determine the treatment, which will be based on the clinical needs of the patient. And again, the clinical assessment is mostly based on neuro, endocrine, and visual. So that's one thing that one should be reminded. And I think that's it.